series. We will have 4 cases that we will discuss. And these 4 cases ما لهم علاقة ببعضهم البعض، يعني مو نفس السيريز مالتنا إنه we were lumping النفروتك ويا بعض and the nephritic ويا بعض. They are mix of cases على أساس إنه we juggle our mind. It is as if إن إحنا عندنا cases على multi-header microscope and we're just you know يعني dealing with whatever we have of the caseload on the day. And yeah, let me know if this works and إذا عندكم any suggestions later on. Okay, we will just talk very quickly على, we will revisit some of the concepts that we talked about لأن it's been a while يعني throughout the month of Ramadan we didn't go through renal biopsy. فشنو نحتاج على أساس إن إحنا we get the optimal renal biopsy result؟ طبعاً نحتاج complete relevant clinical history. إذا النفرولوجيست ما عطانا relevant clinical history نشيل التلفون ونسأله نقول له hello nephrologist ليش مسوي البايوبسي؟ Why did you bring this poor patient and stick a needle in his kidney؟ طبعاً نحتاج adequate specimen obtained by renal biopsy. لازم يكون عندنا adequate sampling of both the cortex and the medulla. And إذا كان it's just medulla only, we will go limited sample and we can't really comment on glomerular diseases. We can only comment on interstitial compartment أو tubules, but we cannot really comment on the glomerular compartment. طبعاً لازم تكون specimen well prepared, and you guys know about all the stains that we need and the different modalities. نحتاج light microscopy, نحتاج immunofluorescence, and if it is available نحتاج electron microscopy. It is for optimal patient care, but when it is not available, in about 60% to 70% of the cases we can get a diagnosis without electron microscopy. طبعاً we need a pathologist who's knowledgeable and experienced and a nephrologist who understands the report. As you guys know, بيكون عندنا تقريباً 10 levels of 3 microns. And we have essential stains. عندنا HNE والPAS والجون سيلفر stain والميسن trichrome. HNE it's important على أساس إن إحنا نشوف inflammation in the tubular interstitial compartment and it will give us an overall feel. لكن if we really want to judge on mesangial hypercellularity, the capillary hypercellularity, إحنا بنحتاج PAS and the Mason trichrome. John silver stain, it will help us in identifying things like spikes in cases of membranous. In cases of crescent بيساعدنا إن إحنا يعني نتعرف مثل هني إن there is a crescent formation by the breakdown of the glomerular basement membrane. بيساعدنا إن إحنا نعرف إن there is مثلاً an MPGN pattern when we have the tram track duplication of the glomerular basement membrane. So we need those. Okay. The patterns of the glomerular pattern of injury, طبعاً this is what is normal. Normal إن إحنا عندنا this is a glomerular tuft. عندنا هني we have the glomerular loops and very thin glomerular basement membrane. Mesangium is just supporting the loops. ما عندنا expansion within the mesangium, and there is not more than 3 to 4 mesangial cells per loop. إذا زادوا عن هذا معناته إن إحنا عندنا we have mesangial hypercellularity, and the loops are patent. Okay, any adhesion هني بيكون معناته إن there is an injury وصار عندنا scarring وصار عندنا sclerosis. thick walls لما يكون عندنا patency okay, of the loops, and ما عندنا mesangial hypercellularity، ولكن we have thickened loops، وهذا يبين لنا على ال PAS. mesangial hypercellularity لما يكون الميزانجيوم expanded and we have increase in the number of cells. إن كل لوب هذه هنا عندنا لوب كم وحدة وياها 1 2 3 4 5 6 okay ف more than 3 to 4 mesangial cells per loop. الاندوكابيلاري hypercellularity اللي هو proliferative pattern إن إحنا يكون عندنا obliteration of هذا هني عندنا obliteration of the glomerular loop إن either إن عندنا inflammatory cells عندنا mononuclear أو leukocytes أو يكون عندنا endocapillary cells swelling. هني over here we have obliteration by شكل neutrophils, so this will make us think of probably a post-infectious, as you guys know. necrosis and crescent. The crescent formation اللي هو extra capillary proliferation أو extra epithelial proliferation, and بيكون عندنا there is a breakdown of the glomerular basement membrane. We'll be able to identify that على الجون سيلفر ستين. وبعدين عندنا all of this proliferation of both the visceral and the parietal epithelial cells اللي هم الpodocytes and the parietal epithelial cells lining Bowman's capsule. We might also have an area of fibrinoid necrosis. Sclerosis هذه crescent when it heals, when it scars over يعني like I don't know a couple of weeks. It might leave us with an adhesion of this loop to the Bowman's capsule, فهذا يسبب لنا sclerosis أو scarring. Okay. طبعا ساعات إن عندنا sclerosis and scarring that is not related to crescent formation in the case of FSGS, where basically it's due to prolonged proteinuria. فإذا thickening of the glomerular loops هذا معناته إن إحنا عندنا membranous glomerulopathy. لما يكون عندنا proliferation within the mesangium, hypercellularity within the mesangium هذا mesangial proliferative glomerulonephritis. لما يكون عندنا proliferation with the endocapillary هذا proliferative glomerulonephritis. لما يكون عندنا thickening of the loops as well as endocapillary hypercellularity هذا اسمه membranous proliferative glomerulonephritis. لما يكون عندنا necrotizing glomerulonephritis. لما يكون عندنا fibrinoid necrosis, this is necrotizing glomerulonephritis, and when we have crescents in more than 50% of the glomeruli, this is crescentic glomerulonephritis. وإذا كان عندنا scarring طبعا أو يعني segmental scarring, this is sclerosing glomerulonephritis. أما هو focal segmental glomerulosclerosis أو global glomerular sclerosis لما it is involving the entire glomerulus. Okay. فهذا كله مراجعة. إنزين الحين بالنسبة حق الimmunofluorescence. الimmunofluorescence عندنا an essential panel تتكون من immunoglobulins, complements and light chains. فالimmunoglobulins أو heavy chains are IgG, IgA, IgM. The are C3 and C1q. اللايت chains are kappa lambda, والفايبرين نستخدمها على أساس إن إحنا نشوف if there is a vasculopathy أو vasculitis أو crescent formation. الكابا لامدا طبعا بيساعدونا in cases where there is monoclonality, and we talked about monoclonal diseases. C1q is important in lupus nephritis. C3 is important in both C3 and post-infectious glomerulonephritis. We will be talking about different cases, but we've covered all of that في discussions مالتنا. بالنسبة حق frequently additional antibodies for immunofluorescence زي ما قلت لكم C4 complement C4 it's more like kind of used for research, ولكن C4D يا أما إنه يستخدمونه it's used used for transplant. أما أنهم يستخدمونه for transplant biopsies على أساس وجود C4D is indicative of an antibody-mediated rejection. يا أما أنه موجود in immunofluorescence أو أنه موجود as an immunohistochemistry. الاديشنال special stains اللي بيكونوا موجودين اللي هم يعني they are not necessary for service بس يساعدون طبعا PLA2R حق primary membranous nephropathy, IgG subclasses, we will talk about those, collagen 4 حق Alport and thin basement membrane, and those diseases, amyloid proteins, when we are talking about amyloidosis, collagen 3 على أساس بعد حق Alport and thin basement membrane والfibronectin. Right. Case 1. نبتدي الحين بكيس رقم 1. Case 1, this is a case of a 16-year-old boy who presents with a 12-month history of intermittent hematuria. على الأغلب كان عنده روتين check-up زين وشافوا إنه every now and then عنده hematuria وعنده trace proteinuria. Okay, for any reason كان يعني this is an incidental finding بس شافوا إنه كل ما يتابعون يشوفون لا هو الولد عنده يعني more than 5 to 10 RBCs in his urine وعنده شوية proteinuria more than 3 grams. And serum creatinine هذا مهم, renal function مالته normal, والcomplements they are normal. All right. Complements ليش مهمة؟ complements مهمة على أساس إن إحنا we're thinking about post-infectious, we're thinking about lupus, okay? The serological workup is negative. Serological workup اللي هو ANA وANCA وNTGBM هذين كلهم serological workup, and in this case it was negative. Okay. خلينا نطالع اللايت مايكروسكوبي. اللايت مايكروسكوبي هذه الجلوميريولس مالتنا and كنا زحمة right في زحمة زين هني زحمة يعني you're thinking like يعني it's very busy, there's something going on, بس زي ما قلنا إن إحنا يعني ال HNA, this is HNA, it helps us in kind of like seeing there's a bit of inflammation هني في tubular interstitial compartment, there's a little bit of يعني atrophy في tubules, there's a little bit of interstitial fibrosis, okay? وعندنا red blood cast أكيها, red blood cast أكيها, زين that's why يبين إلينا إنه عنده hematuria in his urine, okay? إنزين نروح على ال higher magnification نشوف إن عندنا شوية red blood cast, and although this is HNE بس كأننا نشوف إن there is a little bit of mesangial expansion هني, and there is mesangial hypercellularity. Okay, there is mesangial hypercellularity, especially in this area over here, شوية over here بعد. And this is our PAS. And هذا يعني يبين إلينا بما لا يترك مجال إلى الشك إن yes, we do have mesangial hypercellularity. Okay, هذا السيلفر stain يراوينا شيء. I don't know, for those of you who took notice, there is a focus of endocapillary hypercellularity. اوكي هذا يعني احنا طالعنا كل الجلوميرولاي الموجودين على كل الليفلز, بعدين focally in one glomerulus على السيلفر ستين بين إلينا إن there is endocapillary hypercellularity. وسوينا ال IF and everything was negative except for IgA and lambda. And this is the glomerulus, and actually اللي positive هني, this is an intensity of 4, اللي positive هو الميزانجيوم. Okay, هذه اللوبس, ما عندنا شيء في اللوبس, we don't have anything. So when we talk about where is the staining هني, this is mesangial staining. Okay, كأن زي ما قلت لكم كأن it is the أفرع مالت الشجرة, sorry, the trunk, أفرع, the trunk of الشجرة and قلب الشجرة لما تشدي تتوزع. إنزين, it is هي في الأفرع. And not in the أوراق الشجرة. Okay, this is كلها في أفرع الشجرة, كأن الشجرة ما فيها أوراق. So this is mesangial. Okay, and this is in IgA and lambda. Everything else is negative. جينا حق الإلكترون مايكروسكوبي. لما تطالعون الإلكترون مايكروسكوبي لا تخربطون روحكم. Okay, always مثل know your bearings. Okay, there is an expression know your bearings. شوفوا انتونا وينه, يعني واحد واقف يعرف وين رجوله, وين ايده, وين راسه. Okay, بعدين هو يعرف أنا واقف على رجولي ولا واقف على راسي. فدائما دوروا على شيء يعني عارفين انتونا. بودوسايت. اوكي, انا اقول البودوسايت احنا كلنا نعرفها, هاي كانها صبعه هاللون. انزين, هذه activated البودوسايت, we have microvillus formation and كل البودوسايتس هني. فاذا اذا البودوسايت برا معناته هذا الجلوميرولار this is the glomerular basement membrane, معناته هذين الاندوثيليال سيلز, صح؟ هذين الاندوثيليال سيلز, وهذه RBC داخل اللوب. معناته إن هني هذا اللي between the loops is actually the mesangium, وهذه الخلية هذه اللي فارشة روحها, اللي spreading itself is the mesangial cell. And we do have electron dense deposits over here. تشوفونهم? We have electron dense deposits over here. So we have mesangial deposits in this case. Okay, نرجع مرة ثانية. أكيها هذه اللوب of the glomerulus, أكوهم البودوسايتس. ما عندنا, we do not have any electron dense deposits تحت البودوسايتس, لأن لو إنهم تحت بيكون سب إبيثيليال, لا ما عندنا, ما موجودين. ما عندنا أي شيء تحت الإندوثيليال فوق الإندوثيليال سيلز, لأن إذا كانوا بيكونون سب إندوثيليال. أكيها عندنا هذه الميزانجيال سيلز, والإلكترون دنس deposits طالع 1 2 3 4. أكيها they are surrounding the mesangial cell. Over here there's another one over here. أكوها عندنا هني بعد electron dense deposits. So we have mesangial which goes ويا الفايندينج مالتنا مالت IF, إن إحنا immune complexes مالتنا موجودين في الميزانجيوم. Okay, very focally ممكن يكون عندنا subendothelial deposits. Very focally we can have that. And in this particular disease it means إن إحنا we have a little bit of activity in this disease. Oh, sorry. حرقنا الفيلم. So what is the diagnosis, guys? نايمين ولا قاعدين? What is the diagnosis? Yeah, exactly. Yeah. Very well done. ممتاز. Good. تمام. إنزين. So it is IgA nephropathy. All right. So this is IgA nephropathy. The Oxford classification هني هي M1, E1, S1, T0, and we will talk about it. But is there any hypertensive? Is there any hypertensive changes? الشخص اللي قال هذا الشيء عيونه ثاقبة. let me go back and see. yes. شوفوا هذا this لأن قلت لكم هاي من الكولكشن مالتي لا صور from my collection. So the person اللي said this I had to kind of like أعطيكم the most common scenario and basically IgA will be seen in kind of like younger individuals, but yeah, in this case the person did have some hypertensive changes, but it doesn't match with a scenario. So yeah, well done حق الشخص أبو عيون ثاقبة اللي noticed that. Very well done. Yeah. Right. So the IgA nephropathy, the Oxford classification, we look at the mesangial hypercellularity. And we look at the presence of endocapillary proliferation, mesangial hypercellularity either less than 50 or more than 50. Endocapillary proliferation either it's present or absent. Sclerosis either is present or absent, and tubulointerstitial atrophy and fibrosis less than 25 to 75 and then more than 75, so T0 T1 T2. ضافوا عليها بعد الكريسنس فتكون ME mist وبعدين C اللي هو يعني COC1 C2. All right. So like we said, M0 or M1 indicating mesangial hypercellularity in less than 50 or more than 50, less than or equal to 50% versus more than 50% of the glomeruli. E0 or E1 اللي هو either it's present or not. So in this case it was present. شفناها in one glomerulus, even one glomerulus is enough. Sclerosis بعد even one glomerulus is enough, S0 is S1. And like we said, TO, T1, T2 is basically depending on presence of tubular atrophy, interstitial fibrosis in less than 25 to 50 or more than 50% of the renal cortex. Okay, شنو لما احنا يكون عندنا proliferative لما يكون عندنا أول شيء hematuria ولما يكون عندنا proliferative glomerulonephritis شنو ال differential diagnosis مالنا؟ differential diagnosis مالنا ممكن يكون lupus nephritis, right? In this case classes 1, 2, 3 or 4 لأن ال 5 as we know is membranous. ليش هذه مو lupus nephritis؟ لأن أول شيء ال IF it's not a full house. Okay. شيء ثاني إن ال serologies are negative. Okay. الشيء الثالث إن بيكون عندنا tubular reticular inclusions في the endothelial cells by electron microscopy. Has it been lupus nephritis? Why is it not IgA dominant post-infectious glomerulonephritis? Okay, زي ما قلنا كانت تتذكرون احنا تحكينا عن ال IgA dominant post-infectious ويا هذا بيكون almost matching أو شوية less C3 positivity, which we don't have in this case. Okay. الشيء الثاني ال IgA dominant post-infectious بيكون موجود in people who are diabetic or people who had a recent infection. وعلى الإلكترون microscopy بيكون عندنا subepithelial deposits. We will have humps. We will have subepithelial deposits by electron microscopy. Why is this not ANCA-associated crescentic necrotizing glomerulonephritis via mesangial IgA deposits? لأن الglomeruli هني they're not involved in crescents. Although إن إحنا we might have crescents in IgA. وساعات ممكن إنه يكون واجد فلوريد يعني crescents in more than 50%. but إنزين الفرق هني إن في الأنكا as you guys know زي ما قلنا من قبل في الأنكا وفي الانتي جي بي ام اثنيناتهم النورمال glomeruli اللي ما عندهم crescents they will look absolutely normal ما بيكون فيهم mesangial hypercellularity بيكونون looking very very normal فبيكون عندنا glomeruli that are diseased that have crescents وبيكون عندنا glomeruli that look normal بينما في IgA nephropathy بيكون عندنا glomeruli فيهم crescents و glomeruli ثانيين عندهم mesangial hypercellularity. قبل لا نخلص موضوع ال IgA في أشياء indicate for us a more active disease. IgA nephropathy يعني in 30% of the cases it can progress and can lead to loss of the kidney, complete loss of the kidney with repeated insults. بحيث إن ال patients they might يعني go into end stage renal failure ويحتاجون transplant. But وش الأشياء اللي يعني تخلينا نفكر إن إحنا we are dealing with a more aggressive or more active disease. لما يكون عندنا IgG as well as IgA. طبعاً ال IgA لازم يكون dominant. Okay, IgA and lambda. Okay, IgA and lambda. بس إذا كان عندنا شوية IgG بعد مثلاً intensity of 1 or intensity of 2 this means a more aggressive or a more active disease. هذا يعني اللي شافته الستاديز. الشيء الثاني إنه إذا كان عندنا طبعاً يعني crescents formation, the more crescents we have and we have to state the percentage of the crescents. الشيء الثالث is شو اسمه the thought escaped me. لحظة. Yeah, endocapillary sorry subendothelial deposition. كل ما زادت على الإلكترون مايكروسكوبي عندنا subendothelial electron dense deposits كل ما معناته إن there is more active disease. إنزين خلينا نشوف what you guys are saying here. ANCA-associated glomerulitis is post-immune. Very good point. You're right. ANCA-associated glomerulitis is post-immune, but زي ما تتذكرين post-immune does not mean posse as in like the word posse does not mean zero شو اسمه immunofluorescence. It means 2 or less. فساعات ال IgA ممكن إنه يكون مثلا يعني 2 يعني there were cases in which ال IgA على ال IF is 2 plus, all right, and ممكن إنه يعني شيء ثاني I need to tell you إن ساعات في ال IgA في ال IF ممكن يكون segmental only affecting part of the glomerulus وممكن يكون focal. okay, ممكن يكون شو اسمه ممكن يكون يعني involving some of the glomeruli but not all of the glomeruli. فيعني ساعات الجلوميريولاي الموجودة عندنا في الاي اف ممكن ما يراونا اي جي اي بس احنا نشوف mesangial hypercellularity ونشوف شو اسمه red blood cell casts. فهني الالكترون مايكروسكوبي is essential على اساس ان احنا ناكد diagnoses of فزي ما قلنا it can be segmental, it can be focal, and it can be a low intensity. طبعا هذه I'm telling you all the scenarios. It wouldn't be ANCA in this situation لأن السيرولوجيز مالت ANCA بتكون positive. All right. Okay guys, احنا ما نقدر نعيد واجد لأن we have another 3 cases to go through. Sequence of diagnosis. احنا بنطالع الميزنجل hypercellularity بعدين بنطالع ال IF وبنطالع ال EM if it is available. Okay. Case 2. Okay, case 2, this is a 29-year-old man who presented with nephrotic range proteinuria. and normal renal function. Again, a young person, normal renal function, وعندنا nephrotic range proteinuria. The problem هني, the reason إن they have done biopsy مالتنا إن هم they thought إن this person, why is this person having proteinuria? And this is our glomerulus. إنزين this is PAS. خلينا نفتح الباب حق الchat box. What do you guys see? Okay, شيري. عطيتينا diagnosis بس ما عطيتينا yes. Yeah. Good. Very good. فعندنا thickening of the glomerular basement membrane. Very good. Okay, فعندنا loops مالتنا they are thickened بس ما عندنا hypercellularity. There is no endocapillary hypercellularity. ما عندنا mesangial hypercellularity. شيء ثاني we have activated podocytes. هذين البودوسايتس متضايقين في شيء underneath them, it's upsetting them. It might be deposits. And this is our Jones silver stain, and basically عندنا اللي هو السبايكس أو الكوكسكوم اللي هو عرف الديتش إنزين على السيرفيس of the glomerular tufts. And like we said إن هذا مو deposits, لا هذا أينما وجدوا deposits there is no stain. This is like a negative imprint of where the deposits are seen. Okay, we can see هني اللي هو activated podocytes. Okay, podocytes هني wide activated. Why are they activated? لأن في immune complexes تحتهم and they are irritated and upset. All right, so this is the IgG, and I know that you guys know the diagnosis, and this is basically a membranous pattern glomerulonephritis. We don't know if this is primary membranous or secondary membranous. And what we see إن إحنا ذكرونا مساعة إحنا شفنا الميزانجيم. هني the staining كان في الميزانجيم. هني where do we see the staining? We see the staining in the loops. Okay, we see the staining along the loops كأنه قاعد يرسم إلينا. And when we talk about IF, we have to talk about the location. But this is in the loops. We have to talk about the pattern. So this is granular. Okay, then عندنا granular, عندنا pseudolinear, عندنا linear. Okay, and we have to talk about the intensity. This is very high intensity. This is probably 3 to 4 out of a scale of 4. هذا ال IgG. إنزين أنا بقول لكم إن in this case كان عندنا شوية IgG, شوية C3, and both kappa and lambda with no monoclonality. So when the PLA2R, okay, and this was the pattern of the PLA2R, شوية less intense, maybe an intensity of 2 to 3, ولكن same pattern, glomerular loops, and then along the glomerular tufts, and granular. All right. Good. And then so PLA2R الحين positivity مال PLA2R اللي it matches positivity of IgG. What does this make you think of? Somebody writes me. Why is PLA2R positivity important here, guys? Yeah, primary, exactly. Well done. For this supports for us, and this is most likely a primary membranous glomerulonephritis. And then this is electron microscopy, ونشوف إن إحنا ما عندنا mesangial deposits. إنزين وين عندنا deposits؟ أكو هذه البودوسايت مالتنا, and we have subepithelial أكوهم. هني بعد عندنا, can you see this? All of these we have them. These are subepithelial deposits. أكوهم. Again, we have subepithelial deposits. Like we talked about previously, ساعات إن إحنا we have staging system حق membranous glomerulonephritis and من 1 to 4 according to where is the deposits. مثلا the deposits they are just subepithelial أو إن they are digging a bit deeper يكون stage 2 بعدين a bit deeper kind of like they're stage 3 وبعدين إذا كانوا resolved they are stage 4. So this is a membranous pattern glomerulonephritis or glomerulopathy, and it's either primary or secondary. Primary in about 80% of the cases بيكونون اللي هم عندهم antibody against phospholipase A2R or PLA2R. And primary membranous nephropathy will show us positivity for PLA2R in 80% of the cases. Those that in 10% of those cases that do not show positivity for PLA2R, they might be عندهم الانتيبادي حق thrombospondin type 1 domain containing 7A اللي هو THSD7A, which is not very common. It's only seen in 10% of the cases, and sometimes in about 10% of the cases, true primary membranous glomerulonephritis might not show us يعني positivity for any of these antibodies. في عندنا false positive PLA2R in about 20% of the cases. يعني ممكن إنه ساعات عندنا secondary causes for membranous glomerulopathy بس إن they are showing us positivity for PLA2R, but in these cases actually they are weaker, يعني weaker in intensity. They don't match ال IgG. إذا كان PLA2R negative, this is more supportive of it not being a primary membranous glomerulonephritis, and this being due to secondary causes. ممكن يكون class 5 lupus nephritis. How do we make this distinction? بيكون عندنا full house على full house على ال IF, بيكون عندنا TRIs أو tubular reticular inclusions على electron microscopy, بيكون عندنا positive serologies. Okay, drug induced because there is history of taking certain drugs that are مثلا lithium, certain drugs that are related حق membranous infection مثل HPV ممكن يسبب لنا secondary membranous. Some malignancies can يعطونا immune complexes that will deposit within the glomeruli and give us membranous. طبعا all of these most likely in about 80% of the cases they will be negative for PLA2R. Amyloidosis very rarely بيعطينا membranous pattern, and fibrillar glomerulonephritis again very rarely بيكون عندنا. And again in both of these cases في الاميلويدوسز most likely بيكون عندنا يعني monoclonality. في الفبريلاري بيكون عندنا IgG deposition as well as deposition على both kappa and lambda, and fibrillary بيكون positive for DNAJB9. amyloidosis بيكون positive حق Congo red. إذا كان مثلا بتاع light chain أو إن in both of these cases على EM بنشوف fibrils. All right, that basically concludes case 2. Yeah, amyloidosis بيكون negative في silver. Exactly, amyloidosis بيكون yeah, that's true. بالضبط. All right, case 3, 44-year-old woman, recently diagnosed with systemic lupus erythematosus. She has proteinuria of 11 grams per day. That's significant. Urine analysis مالها عندها 10 to 15 red blood cells. That's significant as well. And 5 to 10 WBCs per high power field. Serum creatinine مالتها 1.2. It's not very much elevated. وboth complements C3 و C4 are both decreased. معناته they are being consumed. كان تلاحظون في كل البيشنتس مالاتنا السيرم كرياتينين مالهم مو بوايد مرتفع أو normal. And the reason behind that إن this is an early disease. They are young individuals عندهم واجد على قولتهم reserve of their kidney. احنا يبتدي يعني true renal failure starts once يعني we only have about 25% of the kidney not injured. For these are young individuals عندهم واجد reserve in their kidney. This is early disease. The kidney is kind of like compensating with injury. بس طبعا يعني مفروض ان احنا ما ننخدع واجد بالسيرم كرياتينين. اوكي it's reassuring بس ما نقول يعني most likely هذه ما عندها crescent formation or whatever. Already احنا عندنا hematuria, right? Okay, so نفتح ال chat box. Okay, نجيبكم مني. What do you guys see? Okay, those are saying hypercellularity. وين الhypercellularity? This is H&E, of course. Okay. Nice. Okay, تمام. All right. احنا we have okay. We have okay, so this is let's explain something. Those of you who said crescent formation, طبعا احنا in real life اذا شاكين ان عندنا crescent بنروح وبنطل عليها وبنطالعها في الترايكروم وبنطل عليها على السيلفر stain. But sometimes guys we have to make it يعني a decision whether this is a crescent or not على ال H&E. Because يمكن هذه this particular glomerulus gets cut out. Okay, يمكن ما في غيرها بعد يعني فيها this pathology, so it might get cut out. What we have here هذا شو اسمه hilar blood vessel. عندنا vasculopathy, right? We have vasculopathy هنا. We have يعني basically complements or sorry immune complexes that are being deposited here. It's not really fibrin لأن بيكون عندنا breakdown ويعني بتكون kind of like we will be بيكون عندنا breakdown of if it was fibrin we will have a breakdown. So this is vasculopathy rather than vasculitis. The other thing, and I agree, we do have نقدر احنا we can tell but الأفضل إن احنا نشوفها على special stain. But the reason إن أنا أعطيتكم هني H&E is because يعني sometimes like I said we might not have the luxury of having the same focus على special stain. تتذكرون لما تحكينا عن الendocapillary proliferation قلنا إنه بيعطينا نوع الورقة مالت الوردة the petal of بيكون عندنا lobular accentuation, it will be accentuated. And this is what we have here. أول شيء عندنا obliteration of the we have obliteration of the loops. احنا ما قاعدين نشوف اللوبس. أحد يشوف loops أنا ما أشوف loops. So we don't have loops here. فإحنا عندنا when we don't have we have the loops obliterated معناته إن إحنا عندنا endocapillary proliferation. And I'm sure now we have over here, we have mesangial cell hypercellularity. So we have a case in which we have mesangial cell hypercellularity. We have endocapillary endocapillary cell proliferation. Why is this not a crescent? ما عندنا extracellular hypercellularity, ما عندنا proliferation. We don't have proliferation here. We don't see that. Do you see that? It's not there. ما عندنا proliferation of the Bowman's capsule cells, parietal podocytes, they're flat قاعدين. إنزين الجماعة بتاع visceral podocytes, visceral epithelial cells, الديلين podocytes هم they are flat. Okay, sorry, these are the parietal epithelial cells. For both the parietal and the visceral epithelial cells or podocytes in this instance, they are flat, they are not activated. فما عندنا breakdown of the glomerular basement membrane. A crescent is when we have a breakdown of the glomerular basement membrane وبعدين يصير عندنا الحفلة, proliferation, الانفلامatory cells كلهم يجون الليوكوسايتس ويجون يصير عندنا activation of the parietal and the visceral. So we don't have a crescent here. All right, again, this is our PAS, and عندنا what is known as wire loops, and basically هذين الcomplements, immune complexes, they are deposited within the loops. فهاي it's not really thickening يعني of the glomerular basement membrane as much as it is wire loop Cyrene. You will have to compare between this and your silver stain, and you're not going to see spikes. ما بتشوفون spikes, ما بتشوفون the craters أو holes. You're not going to see this. But we have what is known as wire loops. Right, again, this is a higher magnification of the wire loops. They're kind of like very يعني densely eosinophilic. And this is our EM. Okay, في الEM مالنا عندنا lots of mesangial deposits, واجد mesangial deposits. Okay, and again هذه الميزانجيال سيل مالتنا وعندنا وايد deposits حوالينها. And we have أكيها من هذه البودوسايت مالتنا أكيها activated. أكي هذه بعد بودوسايت. إذا هذه بودوسايت إذا هذا glomerular basement membrane إذا هذه subendothelial cell, and then this is this is an endothelial cell and this is a subendothelial deposits. فعندنا بعد few subendothelial deposits as well. And ذكرون النمش اللي داخل الابيثelial endothelial cell, النمش اللي داخل endothelial cell, this is what we call tubulo-reticular inclusions, TRIs, and these are not essentially pathognomonic of lupus nephritis, but they are supportive of the diagnosis. We can see it in other diseases as well. لكن وجودهم ويا positive serologies, mesangial deposits, and I'm seeing them in the endothelial cells, the TRIs. This is supportive of a diagnosis of lupus nephritis. Okay. إذن هذه الحالة كان عندنا فيها wire loops، كان عندنا فيها endocapillary proliferation, and I'll tell you it is endocapillary proliferation in more than 50% of the glomeruli, and كان عندنا فيها vasculopathy. So, what class of lupus nephritis is this? Yeah, 4. 4, exactly. Those of you who said membranous and who said 5, it is not, لأن ال 5 بيكون membranous، مش بيشبه الممبرانس، ولكن بيكون PLA2R negative، بيكون full house على ال IF، بيكون عندنا mesangial deposits، بس بيكون عندنا sub-epithelial deposits. We will have lots and lots and lots of sub-epithelial deposits. All right, so diffuse proliferative lupus nephritis, basically it's active with mild chronicity, ISNR PS class 4. With NIH activity index, it's out of 24. In this case, calculation طلعت 11 out of 24. With chronicity index in this patient كانت 0 out of 12. Very quickly تحكينا عن activity index and the chronicity index. اللي قلنا إن activity index is out of 24. There is a scale موجود في البيبر اللي خليتها إليكم في الجروب مالتنا على الفيسبوك. You can go there and download the paper. الكالكوليشن تصير على الendocapillary proliferation، على leukocyte infiltration، على presence of fibrinoid necrosis or keratosis، على presence of cellular crescents. values مالت fibrinoid necrosis أو keratosis و cellular crescents تنضرب في 2. presence of hyaline thrombi، wire loops، tubulointerstitial mononuclear cells. chronicity index يكون there is a scale على presence of glomerular sclerosis, على presence of fibrous crescents, interstitial fibrosis, and the presence of tubular atrophy, and the score is out of 12. You can see a reference paper على شو اسمه هذا الفيسبوك. اوكي، آخر حالة حلوة خفيفة. زين، خلينا نشوف إذا عندنا something here. What is the difference between wire loops and membranous thickening? membranous thickening is more. wire loops ممكن يكونون more segmental. And actually yeah, they're more segmental. يعني they're affecting parts of the glomerular. membranous thickening can be more global, and plus احنا قلنا how we make a diagnosis is that we kind of like compare different findings اللي احنا عندنا. فإذا كان عندنا membranous thickening, you're like thinking, am I dealing with membranous nephropathy, or am I dealing with a class 4? تروحين أو تروحون and تطالعون السيلفر. إذا سيلفر كان في مثلا craters أو كان في spikes, this will help you. And of course what will help you also is the IF. إذا كان a granular staining along the glomerular loops in the IF, that will be more going for a membranous pattern. بس إذا كان it's kind of like كأنه subendothelial وكأنه كذي يعني خط هاللون, it goes with it more being a wire loops. Okay, I hope that helps. طبعا بيكون عندنا يعني ويا الواير loops you will have other things. You'll have vasculopathy, you will have endocapillary proliferation, لأن it goes more with it being a class 4. Okay, آخر كيس وايد خفيفة ولطيفة. This is a 45-year-old person. ما قلت لكم مرة ولا رجال. Let's say it's a man. Then presented with worsening of the creatinine levels. فجأة creatinine levels مالته they are worsening. كان عنده البيسلاين مالته حد معين and they're getting worse. And all what we know about this guy is that there is history of gastric bypass. So what is serology tests are all negative. Yeah, complements are normal. And this is what we see. الجلوميرuli مالاته absolutely normal, and let me tell you in IF is negative. What do you guys see? خلينا نفتح chat box. Okay, very nice. Hello. Okay, so what we have oxalate crystals precisely. Okay, and the person who said إن إحنا عندنا ATI, acute tubular injury, is absolutely correct, and that the reason behind this person's rise in creatinine is basically because of the acute tubular injury. Glomerular مالته absolutely normal, they're fine, and we have these transparent, kind of like bluish rhomboid crystals في الtubules, and they are injuring the tubular epithelial cells مسوين لهم flattening. So over here, and يعني they can be يعني difficult to see, so they are polarizable. You can just try to polarize them. So this is a case of oxalate nephropathy, and basically there are parenchymal crystalline deposits of calcium oxalate يؤدون إلى acute and chronic tubular injury. ممكن over the long term يسوون interstitial fibrosis, progressive renal insufficiency. وزي ما قلنا they are rhomboid shapes عادة with clusters or rosette-like arrangements, usually transparent, بس إذا كان فيهم calcium أكثر they can be slightly bluish. Causes of oxalate nephropathy ممكن يكون عندنا hereditary hyperoxaluria, one of the mitochondrial diseases. ممكن يكون عندنا enteric عن patients اللي عندهم chronic pancreatitis, اللي سووا لهم bowel resection حق IBD, اللي عندهم Bind loop syndrome, أو اللي سووا لهم الرو، أو سووا لهم bypass surgery. الناس اللي ياخذون ethylene glycol, الانتي فريز intoxication، أما لأنهم they're trying to commit suicide أو they are يعني alcoholics. إذا كان في vitamin B6 deficiency, or if there is an excessive ingestion of vitamin C أو dietary substances أو يعني stuff that فيهم واجد oxalic acid نفس rhubarb اللي هو محسوب على الفواكه عند الإنجليز، ما أدري شو اسمه بالعربي, parsley and nuts, all of these. Sometimes it's idiopathic. So with that, احنا we conclude the first of our series of case discussion in renal diseases. And if you guys have any questions, إذا كان عندكم أي اقتراحات, was this glomerular of this patient was absolutely normal, ما كان في شيء. What is the cut point to say oxalate the nephropathy حق there is no cut point as such, ما في. Yeah, I looked, there wasn't really a cut point. Okay, thank you guys. شكرا لكم.